Hi everyone, and welcome to episode 5, Fertility 101, in which I talk with another onco-fertility expert, Donna Bell. Let me tell you a little bit about Donna Bell. She's a family nurse practitioner and soon to have her doctorate of nursing, or her PhD in nursing, and will officially be Dr. Bell. Donna has worked at MD Anderson Cancer Center since 2007 in the pediatric division, caring for pediatric, adolescent, and young adults with cancer. She was pivotal in the formation and the continuation of their pediatric onco-fertility consult service. This is a sister episode to episode number 4, Sarcoma and Fertility. As there were many fertility definitions discussed when Wendy and I talked with Dr. Gupta, I had an idea to break those definitions down to more sizable chunks. I'm so excited to bring you all this Fertility 101 chat with Donna. She is not only my friend, but continues to be a teacher in my life. I completed my pediatric oncology training at MD Anderson Cancer Center and spent many hours with Donna in clinic. I made plenty of mistakes and missteps, and she always gave me great advice on how to not only be a better doctor, but a better human. My sister Wendy couldn't make it to this episode, but she'll be back with me in our upcoming episodes later this month. All right, let's get started. Hi, I'm Dr. Lisa Kopp.
And I'm Dr. Wendy Allen Rhodes, and we are the Sarcoma Sisters.
We are friends, moms, wine enthusiasts, and pediatric oncologists.
That means that we take care of kids, teenagers, and young adults with cancer.
We know that cancer is confusing and scary.
And our patients tell us that it's even harder to find information about sarcomas. So we are bringing the experts to you to talk about all the things.
Well, all the things important to you.
Thank you so much for listening.
All right, let's get started. Hey everyone, we have to add in this part every time for the lawyers. The content that you're listening to on the Sarcoma Sisters podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. As you all know, we have the utmost respect for your oncology medical team, and we know that they know you and what is going on with your health the best, so we want to leave all those decisions up to them. Thanks so much. Hi, everyone, and welcome to our podcast. So today I have a very special guest, one of my friends from the blast from the past, Donna Bell, who is a nurse practitioner and actually working on getting her doctorate of nursing as we speak. She is an expert in fertility. She helps to run the AYA fertility program at MD Anderson Cancer Center. And after Wendy and I had our interview with Dr. Gupta, I was listening through and I noted that doctors sometimes do this. We get started talking in doctor mode and we used a lot of medical terms. And I thought, well, I want to break some of these down, but it would be super boring if I just read these terms off and had definitions at the beginning of the podcast. So I thought, I'll send out a little handout, but then I could get my good friend Donna, hopefully, to come on the podcast with me and break some of this stuff down. So welcome, Donna.
Well, thanks, Lisa. I'm so proud of you and your podcast. It's super fun, and I really enjoyed Dr. Gupta's episode. I thought there was lots of great information in it. And so I'm just so honored that you would ask me to be on your podcast, Sarcoma Sisters. So I didn't know this is one of those bucket list items that I didn't know was a bucket list item until now I'm getting to check it off. So in COVID, I'm not getting to do lots of things, but hey, I'm getting to be on a podcast. So that's pretty cool.
Thanks, Donna. That means so much. I'm so happy to have you. And we're missing my other sister, Wendy, because she's actually very close to you right now across the street. She's on service at Texas Children's.
Oh, goodness.
In the mid of COVID, as
Yes.
we were talking about beforehand, Donna and my states are unfortunately competing for a top COVID spot this week in Arizona and the state of Houston.
It is not a race we want to be in.
No, I know. So I thought, because I know part of what you do is when you go and do a consult for families, when their child or young adult or the young adult themselves is diagnosed with the cancer, that then you go through kind of a talk with them and break everything down. And so I was wondering if maybe you could kind of frame it like that.
Sure. And so I think one of the things that in the midst of this cancer diagnosis, and depending on when I'm talking to patients and families, so we see patients and families at before the start of treatment, during the start of treatment, and after the start of treatment, and in the survivorship aspect. And so there is definitely, this is a conversation that can be had at any one of those points, and the goals and the focuses are a little bit different depending on where patients and families are. But I think one thing that I share with families, especially those families who are at the start of their journey, is, this is really about this conversation. We're going to talk about many different things and many different aspects of fertility for your son or your daughter, or even with the young adult. Fertility is something that has it impacts many different aspects of a young adult's life. And so really it's about this conversation. What matters most is us having this conversation and giving this moment to your fertility. For
Yes.
some patients, depending on where they are in terms of their diagnosis and treatment, they really have limited options in terms of fertility preservation. And there can be, cultural aspects, religious aspects, socioeconomic aspects that really also impact, fertility decisions for families and patients. And so it's not so much about what we do after the conversation, but it's about that conversation that matters. I mean, that's really kind of my motto in terms of talking to families and patients about fertility. It's that this conversation matters. This moment that we're giving your fertility is what matters. And so let's talk about, let me give you some information. Let me hear from you what your values, what your beliefs, what your goals are. And then let's set some goals in where we want to go from here, and what is possible.
Yeah, I think that's so important. That's one thing that came up when we were talking, that, sometimes depending on when someone is diagnosed with cancer, there may not be a lot of time to do any fertility preservation. And that can be very disheartening. And then other times, because everything, the priority is the person's life at that moment in time and their cancer. So the fertility conversation might not have happened. And so, like you said, it might happen later. So I think that's so important what you said. It matters about the conversation right now at hand. And this is the moment we're talking about.
Yes, and I think, one thing that I tell families, I think families sometimes can struggle, especially parents. I see patients, and we might be getting a little bit off topic, but I'll see patients in survivorship that come with their parent, just as as somebody who's supporting them. Maybe they were someone who was diagnosed as a child and now they're a young adult. And the parent carries a great deal of burden. I've had parents say to
Mm-hmm.
me things like, I'm the one that consented for them to have this treatment, so I feel like I've made these decisions for them, and now they're facing long-term effects from all of this. And so that can really be a very heavy thing for families to carry. And early on, what I say to families is, worst case scenario is, you don't understand, and we haven't talked about the impact that your cancer diagnosis and treatment can potentially have on your fertility, but we're taking care of that now. We're having this
Yes.
conversation. And so, the worst case scenario is not being able to preserve fertility or to bank. The worst case scenario is not being informed, because unfortunately we know, the literature tells us that there's a large part or past literature has told us that there's this big population of cancer patients that don't really understand, or feel like they've had a conversation in regards to their fertility. And if you think about our consent process, and sometimes the way we talk about fertility, using words as, even as infertility, or, fecundity, or, that it may affect the ability to conceive. Those aren't very clear sometimes
Right.
in terms of what we're talking about. And patients and families are receiving large amounts of information in short periods of time, and being asked to make decisions about what they want to do. And it can be very overwhelming.
Yes, definitely. Yeah, I think that's so important. And I'm just so glad that it's becoming more common,
Absolutely.
and more standard of care that this is
Yes.
done. It was interesting. My partner, Wendy, who's not here, I saw an article that she was part of that just got published in the Journal of Adolescent and Young Adult Oncology, talking about how they surveyed websites across the country to look if there was any mention of onco-fertility or fertility preservation. And it was really minimal. So even though we might be better talking about it, we still have so far to go,
Yes. I think, some of what I've been looking at, is why that gap in care still persists. And, what can we do in terms of it's well understood amongst those of us who take care of pediatric and adolescent young adult patients that, this is a real need. Everyone recognizes that this is a need. And how do we really get that information out there to families? And how do we increase access to care, I think is also a major barrier that we
Oh, yeah.
experience. And so I think that, as we have these discussions and increase, and so that's why I think opportunities like your podcast is a great opportunity to talk about this fertility, because it really gets the information out there to patients and the families. And, one of the things that I've looked at is it seems that when patients and families bring up the issue of fertility, it is such a catalyst to helping overcome barriers within systems to getting patients information about fertility and even into fertility preservation interventions.
Yeah, so true.
When I talk to, let's say, a young man, or, I'll talk a little bit about, the younger adolescent. And I even
Yes.
talk to, parents of, pre-pubertal. That means that
Mm-hmm.
the young woman or the young man has not gone through puberty. And so, the average age of puberty in the United States is about, for girls, it's probably about 10 or 11, and usually by
Mm-hmm.
15 or 17, they're done with that, process of puberty. And for young men, it's about 11 or 12. And so, in young girls, the first sign of puberty is usually development of breast buds. And for young men, they experience changes in their testicles, enlargement of their testicles and their penis. And so, you begin to notice that there's some physical changes going on in terms of their bodies. And, ultimately puberty is about, going through a process of growth and development, of maturing from your child's body maturing into an adult body, that's capable of reproduction. And so this is already for those, for patients and families who are having this cancer, starting this cancer journey during that time, it's already a time that is really can be wrought with much anxiety and nervousness about and insecurity about, just changes going on. It's just a weird time for
Yeah.
patients and parents. And so the fact that, now we have to talk about cancer, and now we're going to talk about sex,
Right.
people just start sweating.
Right. It's too much.
Yes, it's too much. And so usually, what I come in and and then for young men or young women, that they're going to have these conversations in front of their dad or their mom. I mean, it's just mortifying. It can be
Yeah.
mortifying for them. And so I think, having providers who are very comfortable in having these conversations, I think is very helpful. So the more you do it, the better you become at it. And, usually I come in and I sit down and I talk to families and I say, your physician wanted me to talk to you about fertility. And so for some patients, they don't really know what that means. And so what I'm talking about is your ability to have children in the future. And what I'm specifically talking about is biologic children. So children that would share your genes.
Mm-hmm.
And so then, and so I said, so the good news is, we're not going to talk about sex. We're just going to talk about fertility. And then,
Yeah.
usually everybody can, breathe then.
Whew. Yeah.
Yes. because the other thing, and I'm always very respectful in terms of where families are in terms of talking about, these changes in a young person's life, and how that relates, to sex, because different families are at different places, and there's multiple values and beliefs that impact those conversations. And I think being respectful of that really is very important in having those conversations. So what I start with young women is, I tell them that, we women are born with all the eggs or oocytes. That's the other word that you'll hear that reference to, with all the eggs that we're going to have. We don't make any more eggs. And even while we're in our mother's womb, we begin to lose some of those eggs. And that's just the natural process of our lives, throughout our lifespan. And so that, there's this window of fertility that opens when a young girl with puberty, and it closes at menopause. And so, the average age of menopause in women in the United States is about 50. There's this area of perimenopause before that. But so that's usually, there's this window, and that chemotherapy or radiation can have an effect, or even surgery can have an effect in terms of what it does to the oocytes or those eggs. And so some treatments, and commonly sarcoma treatments, have high doses of a drug, of a class of drug called alkylating agents. So things like cyclophosphamide, ifosfamide, and we know that those are the most toxic agents for those oocytes. They destroy those oocytes. And so what happens is that it can affect a woman's, biologic material that they would need in the future to be able to conceive a pregnancy. Now, for some of the higher doses of these types of chemotherapy, it affects, it destroys so many of those oocytes that there's not actually any biologic material left there for women to be able to conceive a pregnancy in the future. Now, usually not usually, but one of the other scenarios is that there is a decrease in terms of ovarian reserve. So, like I said, we girls are born with all the eggs we're going to have. We're never going to make any more eggs.
Right.
And so depending on what the damage is to that ovarian reserve is in terms of what our reproductive capability is in the future. And I say that even with some caution, because it depends also on the woman's age. And so, a 15-year-old is very different than a 35 or 37-year-old in terms of some of the chemotherapy. And women at, who are 35 and receive doses of chemotherapy can really be pushed towards an early closure of that window of fertility, versus a 15-year-old who, probably, will have ovarian reserve just because they go into it with a larger reserve. Does that make sense?
Yeah. So the ovarian reserve is how much you have left before your window closes. Is that right?
Correct. It's kind of that all the, remember, we're born with all the eggs we're going to have. And so that is,
like
our oocyte count. And naturally, as a woman begins to approach, that closure of her window of fertility, it's kind of like, I talk about, like, those are the bottom of the barrel oocytes that are there.
Yeah.
So it's not only, the quantity of oocytes, but it's also the quality of those oocytes. And so, even for women, out of the, this question of, impact of cancer therapy, it's that closure of that window of fertility because of what that ovarian reserve is like.
Yeah. Dr. Gupta had mentioned that it's kind of like having a balloon full of marbles. And
Yes.
so you
Yes.
lose your marbles.
Yes,
So,
you do.
right. So, but you're saying, right, it's the quality of those marbles too,
Absolutely. Yes.
as time goes on.
Yes, that is the other thing, because, and I'm, as a pediatrician, that, really puberty begins in our, as our pituitary begins to signal our ovary, and there's that communication. And so what happens is that you get towards the end of that ovarian reserve, or kind of that bottom of the barrel thing that I talked about is, that the brain is signaling the ovary, but the ovary can't recruit. There's not follicles there that will respond to that and mature that oocyte. And so one of the things that's available for young women is that they can actually freeze or go under oocyte cryopreservation. So that's when you would, what happens with that is that young women can go through kind of a cycle of, of, of medications that stimulate the ovary to mature those eggs. And then, so it's kind of like a cycle of IVF. Where they get medications to be able to mature one of those, some of those oocytes. And, the idea would be to be able to get more than one oocyte, so multiple of these oocytes. And then the reproductive endocrinologist or the reproductive specialist would, that's who heads up those types of procedures. They would remove some of those oocytes, and then they would be able to freeze them and keep them frozen until, such time that a young woman is ready to start a family. And so that would be the young woman's genetic material, that oocyte.
Yeah, so that's when they talk about freezing your eggs.
Yes, that's what they're talking about. It's this process, and usually, it takes about 14 days in terms of taking those medications to be able to have, the oocyte, the ovary be able to respond. And during that time, they're doing ultrasounds, they're doing labs to see, in terms of what the hormones are, and measuring the time in which they think it's best, those oocytes are in best position to be able to be removed. And it is a surgical procedure. It's done with sedation. What they do is they insert a very fine, thin needle in the vagina to access the ovary. And then those oocytes are kind of very ripe, and so they just kind of very gently suction them out, and then they are able to freeze that material.
And I do have a question about that too, regarding the age. And it's not necessarily your age, but for a young woman, and I know we kind of touched on this with Dr. Gupta, because to have that procedure done, it involves transvaginal ultrasound. And, depending on how old the young lady is and where they are in maturity, it could be, psychologically, I think, a lot and maybe too much.
Yes.
So I was wondering, how do you bring that up with families? Because you don't want to assume one way or the other. So how do you figure out, like, when someone's 16, because they would maybe,
Yes. And so I think, one of the things that I talk about with young ladies in their families is, I think also approaching it in terms of what matters most is not this decision that you're going to make. What matters most is the conversation that we're having. For some young women, they look at me or the parents will say, her best friend is adopted. And so, it's funny. She's always talked about that, for some reason, if she wouldn't be able to have kids, she would want to adopt. And so that's a decision that was made long before, this cancer experience. And so I am very respectful of that, because I think that, again, what we're talking about is this biologic family building, but there's many different ways to build a family.
Yes.
And so, and for some young women, for some teenagers, there sometimes can be pressure from parents in terms of, I want you to do this because I know this may not be important to you right now because you're 16 or 17 or 14, but this is going to be important to you in the future. And sometimes it's that burden of the parent in terms of, like, I understand this in a much deeper sense than you do, just from life experience. So I feel like this is something that I need to make sure that that's offered to you.
Yes.
And I think that is really difficult, because I totally understand where parents are coming from in terms of, being able to preserve fertility, and helping, their teenagers be able to understand the importance of that. But I also say, to families, and I say, the most important thing is this conversation, and she may not be ready to undertake these kinds of procedures. They're invasive. The other consideration is, is she a patient that can, have a delay in therapy? Because this does take, at minimum 2 weeks. And the other thing is that for some for some women, they don't respond to this as ovarian stimulation. And so you've put off therapy for 2 weeks, and there's a cost associated with that that's often not covered by insurance companies. And so now you're this far into the game. And so really it's about, having that discussion and it be a shared decision. And I would not, I think, encouraging families to listen to to their teens in terms of what they feel comfortable in doing, because the last thing we would want is, this sense of having your body violated or having something done that, you weren't in agreement with, because these are shots and these are invasive procedures. So I think, while adolescents can't consent, by law because they're minors, I think having that discussion with them in terms of, what do you feel comfortable with? And sometimes they're just trying to process the cancer diagnosis, and having this conversation is just too much.
Mm-hmm.
And so I
Right.
think the other piece of that is, I talk about having, your fertility assessed after treatment. And
Yes.
so usually what we talk about is, for patients who, this is not an option for them to preserve fertility prior to therapy. I think it really becomes crucial as well for patients who maybe aren't getting high dose chemotherapy, high doses of alkylating agents, but are getting, what we would consider to be intermediate risk. And so then what does that do to that window of fertility? We really don't currently have any great tests that everybody can agree on that are going to tell us, well, this is your chances of, becoming pregnant. Because that's really what people want to know. Like, what are my chances of becoming pregnant in the future? And there's just not a good way to be able to measure that or to give you, numbers. And so I think that that's difficult as well. But, that's why I think that not only this conversation about fertility is important, but also visiting with a reproductive specialist at the beginning of treatment. I usually don't go into detail in terms of what these fertility preservation interventions are, because I think that the reproductive specialist does a much better job of explaining that, of what that all entails. But I do encourage them to have that conversation, and to, we're fortunate enough at MD Anderson that we have two great reproductive specialists that, see our patients and we refer to them. And so, they're very attuned to having these conversations, with young women and their families in terms of what all that entails, and, having it in a way where it's not associated with guilt or shame that I am or am not making some decisions. But I think, having that initial conversation, establishing that relationship with that reproductive specialist is important, because our recommendation is that once you have completed treatment and you're a year off of treatment, to go back and to start having, your ovarian reserve measured. There's some blood tests that can be done. Again, ultrasound is really the other measurement for ovarian reserve. And what's
Yes.
really important is that serial following. So that yearly following, because once things begin to change, and if things begin to change, then there still may be an opportunity to intervene at that time to preserve fertility. And then by then, this young adult, this teenager's had some time to sit with this idea and to consider more what their goals are in terms of family building.
Yeah, that makes so much sense. It's like, this is not our only chance, at the time when
Yes.
everything else is going on. It's a new diagnosis. You just found out you had cancer. And then now it's like you have this other conversation. And I think that's so important, why it's so important, the work that you do, to let them know, like, we need to have this conversation. But just like you said, it's a conversation that's important. It's not that this is your only chance that you're going to have to try to figure out what to do in the future.
And I think the other piece for young women is that our ovaries are good for more than just having babies.
Yes.
And and so,
Yeah.
there's this whole other piece in terms of, what types of, they support our bone health, our heart health. And so if you're having a decline in your ovarian function, what are things that can be done to intervene to help support that? So I think that that's also very important. And then, one of the things that I tell, young ladies, and I just, for me, I just assume everyone's having sex.
It's much easier
And
that way.
so, yes. And so I have conversations in terms of the importance of contraception during treatment. that is the worst case scenario. We would not want to put someone in a position where they would have to make decisions about, what to do with a pregnancy or delays in treatment to their cancer care, because they weren't fully informed. And I tell young women and young men, never use your cancer diagnosis as your method of contraception, because it will fail you. So whether that be, during treatment or after treatment, if you are not intending to conceive a pregnancy, you need to use a method of contraception.
Yeah, that is so important. And I think that can't be stressed enough.
Yes. And so I think, that's the other part of the conversation in terms of, when you're sitting down and discussing these things with families.
Yeah. And I think, like you said, it is so important for the medical people to bring this up, because, families are at such different points as if they've ever had a conversation with their child,
Yes.
Or whether their child is 17 or 12,
Yes. Yes.
So it's like, it's so important, because if not, that conversation isn't going to be had, especially in a time of stress when you have a new cancer diagnosis and everything else.
And I think sometimes some of these unanswered questions follow patients and into survivorship, and they have an impact in terms of how they view themselves, and can impact issues with confidence and relationship. Feeling, I've had young adults who've shared that, maybe because they're unsure of where they stand in terms of fertility, they have shied away from establishing long-term meaningful relationships. Like, is a guy really going to want me, or is a girl really going to want me if, they find out I can't have children? And so these questions about fertility, unanswered questions about fertility, really haunt young adults long into survivorship. And so I'm always of the opinion that you just name the big elephant in the room, and that always makes it become smaller.
Yeah, definitely. Before you go to young men, I just had one more question about your experience, because I know when I was practicing here in Tucson, we never ended up having a young lady go do the frozen ovarian tissue. And I just didn't know if you had any experience with that, and just kind of like what your experience is, in case some people had heard that term. And
yes, so ovarian, freezing ovarian tissue is another method of fertility preservation. Now, it's no longer considered experimental, but one of the things that it's taken with a lot of caution is in terms of reimplanting that tissue, especially in different types of cancer, because the last thing you would want to do is reintroduce cancer cells into a person's body, into a woman's body. And so there are, there's research looking at how else to use that tissue. So I think that will be really interesting to see. And, it's another thing that I tell families is, this is kind of where the science is right now. But by the time, hopefully, that, you would need to use some of these tissues, our science may be in a different place. We don't currently have an ovarian tissue protocol here at MD Anderson, but it's something that, we've been working to be able to offer to young women, because I think that one of the advantages of it is that taking this tissue, there's not this delay of therapy. But then on the other side, it's what do you do with this tissue, and the risk of reintroducing cancer cells is a real risk, and so it's one other thing to consider.
Yeah, because with the eggs, we're not concerned about that, but if you take an actual chunk of the ovarian, is it the ovary?
It's of the ovary, yeah.
Of the ovary with the oocytes in there, then you have that risk. Yeah.
Yes.
Well, thanks.
Yes.
Thanks for answering that, because that is one of the things that one of the questions that I know comes up too. But we can spend a couple minutes talking about the guys.
Yeah. So when I talk about, fertility, the effects of cancer with young men on their fertility, it's very similar. So depending on what types of treatment they're receiving, they can be at high risk, intermediate risk, or low risk. And there's some therapies as well that we don't really know what in terms of what your risk is in terms of fertility. And so for young men, I ask the same question, have the same discussion in terms of really this is about, do you know you want to have biologic children in the future? And for young men, because options for fertility preservation are not as expensive or invasive, really, I recommend that if a young man knows that they want to have biologic children in the future, even independent of what their risk is from chemotherapy, that they go ahead and bank. I think one of the other issues that we face is, obviously when oncology teams make treatment plans, it's, this is what we believe will be, able to, address your cancer as we know it to be best. But, unfortunately, things don't always go as planned. And so what happens is, if there needs to be a change in therapy, it's usually, increases the intensity of the treatments, and
Yes.
that also can increase the risk for fertility. So someone who, initially, I see a lot of patients with Hodgkin's lymphoma, and so that's considered low risk in terms of fertility. But, if they recur, or if there's not, they don't initially respond to therapy, then, other more intense treatments that really change the fertility risk come into play. And then that window to help to preserve fertility is gone because, that's before they have received therapy. So I think, that's the other piece. And I think for young men that really plays into it because it's not as invasive. What they would need to do for young men to preserve fertility is to bank sperm so that they would have to obtain a semen sample. Of course, with that comes a conversation about masturbation, like how do you obtain a semen sample? And again, depending on the age of the young man, that can be a really uncomfortable conversation for them, and it can be embarrassing. And so usually what I talk about is in preparing families for if a young man decides that they want to sperm bank, usually what I will say is if they're doing that, if they're sperm banking when they're inpatient, I usually tell the parents, just leave. They need to have their privacy, and we try to assure that they have their privacy in the inpatient unit. If they are going to a sperm bank to bank, they'll obviously have their privacy there.
Right.
And one of the things as well for young men is that sometimes cancer itself can have an effect on a man's fertility, their ability to make sperm. And, when men are sick, their sperm count drops just because your body naturally, reserves energy for survival and not reproduction. And
Right.
so, even if a young man's had, fevers or a lot of pain, that can all affect your sperm count. And so, the thing that I tell them is that sperm are like Marines. You only need one good man. And so even if you have a low sperm count, as long as there's some live sperm in that ejaculate, they are able to freeze that sample. And what they do is they'll break it up into smaller vials and they freeze those. And so, in the future, if you need to use those for reproduction, they'll just thaw them as they need them. And so that's also that's something that's available for young men. What else? What other questions about that? In survivorship, I'll say that sometimes young men have, or when I see a young man in survivorship and, there's a question about, well, I don't really know if I'm able to have children or not. I had this conversation or I had chemotherapy. I always recommend a semen analysis, and it's the same kind of thing. It's a semen sample, and what they're looking for is, are there any live sperm in that ejaculate? I think that, if there's if a young man has a low sperm count, or if there's not any sperm in that sample, then I would recommend that they see a male infertility specialist, because sometimes there are other things that can be done in terms of looking for sperm. So sometimes there's something called testicular mapping that's done, which
I think you all talked about testicular biopsy as well.
Yes,
which
yes.
so it's something similar. So testicular mapping is something that they do, with a testicular biopsy. Obviously they have to make an incision into the testicle and remove some of that tissue. And what they're looking for is, are there some sperm, because sperm are made in these little tubes, these seminiferous tubules in the testy. Sometimes you can find sperm in there that haven't made it out or won't make it out to semen. And so they can do testicular mapping, and the young man would be sedated as well. Fathers usually cringe when I talk about about this
Yep.
procedure, and so they'd be sedated, and what they do is they take a small needle and they take samples from different parts of the testicle, looking for sperm. And so sometimes they're able to find sperm there. And so they would be able to use those sperm extracted from that for, assisted reproductive therapies, like IVF or, back to the marine analogy, as there's something called cytoplasmic sperm injection. And so that's where they actually take one sperm and inject it into the oocyte. In IVF, what IVF is, it's a method of assisted reproduction in which you combine the egg and the sperm in a dish. And I would say they kind of play. And it's, which sperm actually make it
who
into
wins?
the egg to fertilize. Yes. Where this ICSI is where they actually take the sperm and put it inside of the egg. So it kind of help it along a little bit more.
That's so amazing, all the things that could be done. And I think just
Absolutely.
like you said, it's just like for women, why it's so important, because I've had the experience, and I'm sure you have too, where I've had a young man who, because of pain, fevers, whatever it is, he's unable to sperm bank. And that's so,
Yes.
again, devastating for them, on so many levels, I think, especially for young men. And, but just to remind them that it's okay, we'll still have other options. And like we talked about before, about having a biological child or not, but that it's not the end, there's still other options in the future.
Yes. And I think, I've had some young men, some young adults who, just because of kind of their clinical condition, are have trouble banking. We've even had some patients where we've, had to help in terms of, ordering some Viagra to help in terms. So, it's about having that conversation of this is the setup. What does your energy level look like? What are you feeling like, just clinically? And, because obviously, it's a new cancer diagnosis, and it is something, where sometimes it's just the expectation of like, this is what I got to do, and I got to do it.
Right.
And I've only got this much time, and that's a lot of pressure.
Yeah, for sure. Yeah.
And so, sometimes that's the obstacle that young men have to overcome.
Right.
And so I think, taking some of that pressure off is always helpful. And then the other thing, just like young women, I tell young men that, they can have a semen analysis once they've completed treatment and they're at least a year off therapy. They can have a semen analysis to look to see if there's any live sperm. For young men, sometimes the question is, so I banked sperm before treatment and now I'm off the therapy. So what am I supposed to do? Keep those samples banked there for like forever? So they kind of want to know where they stand in terms of their fertility. And so a semen analysis, it's really low cost. And so that's something that can be done. I think the other piece to talk about is the financial piece of all this. Like I said,
Yes.
Unfortunately, this is not something that's covered by insurance. Some states do have a mandate in terms of, coverage from insurance companies, but for medical health insurance, but that's not something that we have across the board. And so depending on where you are, your coverage will look different. In Texas, we don't currently have a mandate. And so our patients are paying for out of pocket for these procedures. For young men, here in this area can range anywhere from about $350 to $1,500 to bank sperm. It just depends. They do require infectious disease testing prior to banking. And so sometimes that's part of the cost that's involved as well. And that's just something that that's just standard requirement. For young women, there are, resources in terms of financial assistance. So Reprotect, Burnus Purse offers, reduction in terms of those banking fees, because, you pay every year to keep that sperm banked.
Mm-hmm.
So that's also something, that's a consideration for young men. And then for young women, Walgreens has a great program, Heartbeats program, that helps to provide some of the medications needed for that ovarian stimulation that we talked about if they're going to undergo oocyte cryopreservation. And then also Live Strong does resources as well in terms of helping with some financial resources. They help negotiate, cost with certain centers that they have agreements with. So there are resources out there, but unfortunately for young women, we're still talking up to like $5,000 and $7,000 out of pocket to have these procedures done. And sometimes that, that limits a woman's ability to be able to preserve fertility prior to therapy. That's just a real barrier that, of course, I'm hoping that we're able to overcome someday. The World Health Organization does define infertility as a disease of the the reproductive system. And so, and that infertility does generate a disability because there's this impairment in function. And so, really, we would hope that we would be able to move forward in terms of being able to offer, health insurance coverage for, this is called iatrogenic causes of infertility. So it's, for chemotherapy related or cancer therapy or radiation therapy related infertility. Because, this is something that is very important to patients and families, and the fact that, there's decrease in access to care. There's this, rationing of care that happens because of this is really, kind of one of the, don't get me started, it's one of the injustices in our healthcare
Oh my
system.
gosh.
I'm going to get my placard out and start protesting, but
I know.
And so it's really, and if you think about it, something again that, women many times feel more of the weight of that injustice just because of the cost. And it's not to say, those are, those are invasive treatments. And so they do come, with a greater cost, and it's very sophisticated technology that's, needed. And so really, if you can write your congressman.
Yes, please. Yeah. Everybody write and vote.
Yes, it's very important to advocate because I think we have a responsibility to all of our patients and to, adolescents, young adults, pediatric patients at large to be able to offer these services. Yeah.
Thank you, Donna. That's just so important.
Sorry.
And
no,
don't apologize, especially for that. No, I think that's a message we all need to hear, and we all need to be an advocate, because that's the only way, to get things done. Not just to agree with it, but to make a step toward it, because it's so incredibly frustrating.
Mm-hmm. Mm-hmm.
And I'm glad that you brought up, that was like one of my things to talk about. I put cost on here.
Yeah. Oh, good.
Yeah. Well, thank you so much. And I want to be respectful of your time. So I just want to say, I appreciate you so much going through all this. It's been so helpful, and I know it's going to help so many people. So I really appreciate it.
Yes, I love to talk about fertility. I'm very passionate about it. And again, it's that conversation that matters. And so, to families that are it's just an honor to work with, patients and families as they, face this cancer journey, to walk alongside of them and to just provide them information and, to really help and facilitate and advocate for them in terms of, what those goals are.
Yes. Thanks. Well, they are so blessed to have you too. You are the best.
I love you, Lisa.
Love you too. We'll talk again soon. Thanks for listening. Follow us on Facebook, Instagram, and Twitter, or find us at sarcomasisters.com and drop us a note. If you enjoyed our podcast, please share with a friend. Thanks so much. Till next time.